Africa. And I'm also going to be your host this afternoon. While we're just waiting for participants to join, won't you please greet everybody in the chat, tell us who you are, what your profession is, and where you hail from. We believe we have some international visitors joining us this afternoon. So please do feel free to greet each other in the chat. All right, so my co-hosts for this afternoon, our sister Tracy Rawlins. Tracy Rawlins is a professional nurse by qualification and also did the palliative care diploma at the University of Cape Town. And Tracy is the training manager at Patch South Africa. Next up, we have Dr. Julia Ambler. Dr. Julia Ambler is the Deputy Director for Umduduzi, which is a pediatric palliative care project based in KwaZulu-Natal. And Julia also lectures in palliative medicine at the University of KwaZulu-Natal, and also is involved with presentations through the Medical Protection Society of South Africa. Our next co-presenter is Dr. Khakhu Mathivha. Khakhu is a neonatologist who also did the palliative medicine diploma, and she's currently working at Nelson Mandela Children's Hospital. And then I'm, as I have already introduced, the chairperson of Patch South Africa. Right, there's just a slide there of all of the organizations that are represented in our presentation this afternoon. So as you might know, or if you don't know yet, Patch is an umbrella organization. So we are a network of organizations and individuals across South Africa that provide pediatric palliative care, either in an NGO capacity, in a private capacity, or in the public sector. All right, I'm now going to hand over to Tracy Rawlins, who is going to introduce us to the Perinatal Palliative Care book that has been recently printed by Bettercare. Thank you, Tracy.
Thank you, Michelle. And good afternoon to everybody. And thank you for this opportunity to talk about our book. Sorry, apologies. Our Perinatal Palliative Care Bettercare book has just been launched, and today's the first webinar where we will be working from the book and discussing the book. So we're very privileged and we feel very honored to be able to share our book with a big domain of people out there. Our book is called the Perinatal Palliative Care. It's a guide to supporting families when a baby is at high risk of dying before or shortly after birth. It was written for anyone who cares for pregnant mums and families when their baby is expected to die, maybe before birth or soon after birth. We've worked very closely with Bettercare. This is our second book we've published with them. Our first book was Palliative Care for Children, and it's been a very exciting journey for all of us, especially being able to now launch our new book. We've been very fortunate to have generous funding from the Discovery Fund, which has helped us put this work on the book and publish it. It was put together by a team of experts and from Patch, and in the book are 5 sections that we've done. Up here are the introduction to perinatal palliative care, providing palliative care in the antenatal period, care and support during labor and immediately after delivery, and then care and support during the neonatal period, and then there are some key considerations in perinatal palliative care as well. The books cost 160 Rand each and are available to be purchased from our website at www.patchsa.org. There will be a link in the chat for you to be able to go onto our website and find the book. The book can also be read and worked through free online at Bettercare, and their website is there. And there to order the copy is the 2 addresses where they can be accessed. Thank you.
Thank you very much, Tracy. All right, just in terms of the format for this afternoon, so our 4 speakers will speak in series. Please do, if you have any questions that arise during any of our talks, please do feel free to put them in the chat. And then we will have opportunity at the end of this webinar for question and answers. And please do all, I see there are a few speakers, a few participants that are not muted. Please do mute your microphones. We don't want to have any interference in the background. Thank you very much. All right, so I'm going to kick us off this afternoon by actually introducing you to the concept of perinatal palliative care. So as the name suggests, it's the care of a fetus or a neonate or an infant with a life-limiting condition. And it's an active and total approach to care. It's not the passive thing we do when there's nothing more that can be done. We're very active and very intentional in the care that we provide. And like with general palliative care, this should be started from the time of diagnosis and should continue throughout the child's life, including the terminal phase and extend into the bereavement period. Palliative care is holistic and needs to include physical, emotional, social, and spiritual elements. And our main focus really is on how do we improve this baby's quality of life for as long as possible, and how do we also provide support for the family. It includes the management of distressing symptoms, the provision of breaks and respite, and care through death and into bereavement. And this is a definition that is brought to us from Together for Short Lives in the United Kingdom. So just a little bit of a revision for the terms that are commonly used in perinatal care, for those of you who may not be actively engaged in this field at the moment. So we obviously look at pregnancy in terms of 3 semesters, the first, the second, and the third trimester. And then we have the period after birth of a live baby. So when we look at what is a stillbirth and what is a miscarriage, we really look at viability. So in South African terms, our cutoff is 22 weeks or 500 grams. So if the baby dies before 22 weeks or viability, that is known as a miscarriage. And if it occurs after 22 weeks, it is called a stillbirth. For the neonatologists out there, I'm sure you're all very familiar with these definitions as well. Preterm baby less than 37 weeks, term baby between 37 and 42, and a post-term infant of more than 42 weeks. I think in the important parts of perinatal palliative care is recognizing that death can occur anywhere along this spectrum. And we talk about an antepartum stillbirth when the baby dies before the onset of labor, and an intrapartum stillbirth is actually a baby that dies during labor or shortly before birth. And then for babies dying after birth, we classify them as either early neonatal deaths if the death occurs in the first 7 days, and a late neonatal death if the death occurs up till 28 days. All right, so just so that you're all aware of the terminology that we'll be using throughout this webinar this afternoon. All right, so you might ask, well, why is this such an important thing to discuss? Why is it important to have a whole webinar on perinatal palliative care? And I really do think that it has actually been something that has been quite neglected. And there's a lot of families as a result that have actually had to endure unnecessary suffering that could have had more support. So really the main aim of perinatal palliative care is to relieve suffering and to preserve the dignity, both of the unborn baby, but also of the family, and to promote quality of life for the baby and also for the family. I think one of the big things with perinatal palliative care is there's a lot of teams involved. There's an obstetric team, there's a labor ward team, and there's a neonatal team. And it's quite difficult if you don't plan for this to actually ensure a continuum. So it's really important that we actually discuss this amongst ourselves as a multidisciplinary team, so that we ensure that there's no falling through the cracks and that nobody is unnecessarily left unsupported. And this also includes after death, because I think a lot of times these families go home after having a very traumatic experience and often don't have access to post-bereavement care. But I think also very importantly, and I mentioned in the beginning about the intentionality of perinatal palliative care, that, rather just letting things happen by accident in an ad hoc manner, causing unnecessary trauma to families, we really, through the practice of perinatal palliative care, try and actually preempt catastrophes and disasters, and try and guide decision-making and planning. And in so doing, actually respecting the parental wishes and actually asking them what their preferences would be before you actually land up in a traumatic situation. So we make the plans before the baby is born, before the termination is done. And it really, I think, being more intentional about care around this period enables families to actually have quality time with their baby, however short that might be. They have time for bonding, they have time for creating memories, irrespective of whether that baby is born alive or dead. And I think, as mentioned, and as part of normal palliative care, this journey needs to start from the time of diagnosis and continue throughout the stages that I mentioned, and include bereavement support for the parents, but also, very importantly, for the siblings of that baby, who often get a little bit neglected with all of the attention and focus being focused on the ill baby. All right, so which babies would we refer for perinatal palliative care? So this comes from the Americans, and we've got 5 categories here. So category 1 are conditions that are not compatible with long-term survival. So babies that are really not expected to survive, mostly due to severe organ dysfunction. So a common example there is a baby with bilateral renal agenesis or a baby with anencephaly. We don't like to use the words incompatible with life, because it's really not a very gentle thing to say to any parent. Category 2 are diagnoses that have a high risk of significant morbidity or mortality, but not necessarily eminently terminal. So a child with severe bilateral hydronephrosis who still has some renal function, and a baby maybe with hydrocephaly. So there is some expected survival post-birth, but it's going to be limited. Category 3 are really for our babies where there's extreme prematurity. So these are babies born at the margins of viability, especially where it has been decided beforehand that we're actually not going to be able to offer these babies intensive care. Sometimes this is the situation that we are stuck in when we have resource constraints, especially in low middle income countries. Then category 4 are postnatal clinical conditions, so a condition that's diagnosed postnatally, that have a high risk of severe impairment to the child's quality of life, and especially when these babies are already receiving some form of life support that may at some point require withdrawal. So a classical example of a category 4 neonatal palliative care condition is a baby with hypoxic ischemic encephalopathy. And then category 5 are postnatal conditions where we feel that the baby is experiencing unbearable suffering in the course of their illness. So something that is eminently treatable, but unfortunately causes a lot of protracted suffering. So a very common example there is babies with severe enterocolitis who often end up with short bowel syndrome, and we can't send them home on TPN. So just some examples of conditions where we might expect to apply a perinatal palliative care approach. Obviously, as we've mentioned, care should be started at the time of diagnosis. For the points of this webinar, and also how we kind of structure our perinatal palliative care, is we tend to look at 3 distinct periods. We look at the antenatal period, we look at the intrapartum period, and we look at the postnatal period after the baby is born, which obviously extends into the bereavement phase. All right, so I'm going to actually be covering the antenatal period, and then I'm going to be handing over to Julia, who's going to be covering the immediate postnatal period. So if we have a look at the antenatal pathway, that usually starts with the antenatal diagnosis of a non-curable condition, obviously often on an ultrasound. And obviously the main and most important thing that needs to happen at this point in time is that bad news or that significant news has to be shared with the family. And that's the point at which their life is literally turned upside down. And the manner in which that news is broken is incredibly important. And part of our book and our course looks at giving you tips and skills in terms of breaking that bad news. But we're not going to be covering that this afternoon. So obviously after that news is broken, the family really is facing a difficult decision. And often there's 2 pathways. It's, do we actually decide to terminate this pregnancy, or do we decide actually to continue the pregnancy? And perinatal palliative care is applicable to both pathways. It doesn't matter what the mother or the family decides. Obviously, there's a lot of different repercussions to an early termination versus a late termination of pregnancy. And both these mothers are going to need, and families are going to need quite a lot of support. If they decide to continue the pregnancy, then obviously if it's a very severe condition, sometimes death will occur before the baby is born. If that is before 20 weeks, we call it a miscarriage, as already mentioned. If it's after 20 weeks, we call it a stillbirth. Then sometimes, unfortunately, death happens during birth and labor, which is called an intrapartum death. And then if death happens afterwards, it's either an early neonatal death or a late neonatal death. But I think a very important thing to remember is that sometimes we get it wrong. And sometimes we actually have unexpected survival or recovery, or sometimes an incorrect antenatal diagnosis. And I just kind of put that in this diagram just to remind you to also be prepared for the unexpected. All right, so just starting with the termination of pregnancy pathway, I think a very important thing in this period of time, there's often a sense of like we needing to rush, and unless there's really a severe preeclampsia or some maternal indication, there really is no rush to make this decision. And it's an important decision. And if it's not made properly or it's made under duress, then a lot of moms bear a lot of guilt. So we really need to actually give families enough time to grapple with this very difficult decision. There's a lot of tasks that need to be done once this option is on the table. And the extended family needs to be informed. There's often a need to arrange extra support, extra family support, spiritual support, psychological support. The siblings need to be told, especially if they already knew that mommy was pregnant. So there's work that needs to be done in that respect. And then in keeping with respecting the dignity of the baby and creating memories, irrespective of the gestational age, parents really should be given an opportunity to give that baby a name and to make funeral arrangements if that's going to be the case. So there's a lot of things that need to be done, even if the families decide to terminate that pregnancy. And then obviously after the termination is done, there's a routine care that needs to take place, but we also obviously need to consider, I know in many cultures, stillbirth or miscarriage isn't always considered a significant death, but for that mom and that family, it really is. And we get a lot of, unfortunately, complicated grief if bereavement isn't properly done in this period. So we really need to intensify, if we're not able to provide it ourselves, but find other resources to provide bereavement care and support to families post termination. Obviously, if the termination was done for a genetic condition that's possibly repeatable, there's a very important need for follow-up and ongoing genetic counseling. All right, so that's on the one hand, and then going down the other pathway, if the family decide to continue with the pregnancy, if you do have a perinatal palliative care team, most of these teams start looking after the mom after viability, so from 22 weeks. Depending on your resources, we might be able to refer earlier. I think in most settings, ours included, there are no perinatal palliative care teams, so we actually have to mobilize one. We need to mobilize our existing resources, we need to create a team around the mother and family, and we need to ensure a continuum between the obstetrics and neonatologists and midwives, so that even if we don't have a functional team, we at least can ensure a continuum and ensure that nobody gets dropped in the process. And obviously, if in the absence of specialists, we can all still continue to provide a palliative care approach. And really, palliative care needs to be everyone's business. So even if you don't have a team, that's no excuse not to provide perinatal palliative care. All right, so some of the tasks that are required when mom elects to continue with her pregnancy. Obviously, there's also grief. Even if the baby doesn't die, she still is actually grieving the loss of a baby that she had hoped for, a normal baby, a normal, healthy baby. It's obviously very difficult to embrace a pregnancy where you know from the outset that there are complications, and many of these moms might struggle to bond with their baby. So there's a lot of counseling that needs to go into that. Obviously, we also need to assess how much the parents know and how much they want to know, and we need to be able to provide that information in a way that's actually manageable for them, especially in terms of making decisions. I don't think it's fair for us to expect parents to make decisions that we are struggling with. So we really need to make sure that, number one, we empower them, but we also explain it to them in a way that is understandable. And then obviously, once the parents have that knowledge, we need to be able to establish what are their wishes and goals, so that we're not being paternalistic and deciding things for them. And a very well-informed family will then be able to participate in actually making a birth care plan around their values and their goals. And also, being intentional about continuing with the pregnancy, especially if we recognize that the baby might not survive long. If we can actually start working before the baby is born, we can can already do things that will help to facilitate bonding, naming the baby and creating memories even before the baby is born, especially if the baby doesn't survive long after birth. It's also a very important time to also recognize other spiritual and emotional needs of the family. And also the same process applies to babies that are stillborn. So it's not just for the baby that actually goes to term. All right, so that's just a little bit about antenatal care of the mother who either decides to terminate or to continue with her pregnancy. We're now going to briefly have a look at the perinatal palliative care process. And really, this is the core of perinatal palliative care planning. And the main goal really is to actually support the parents and help them to actually identify their goals. It's really much easier working with a family where you already know what their wishes and goals are. And you can't kind of establish that in the rush of a labor ward or just after a baby has been born. It's much more important to actually have nice conversations before the baby is born, where you can ascertain exactly where they stand, because it's very difficult and it's really unfair to expect people to make difficult decisions in the throes of a lot of emotion and a lot of pain from labor. All right, and then obviously once you've established their values, and we need to decide, is this baby likely to survive? If he is going to survive, how long will that be? What are the kind of complications that will arise, and how will we manage them? How interventional will we be? Will we resuscitate? Will we not resuscitate? So these are all of the important discussions that need to happen before the baby is actually born. So, you know, a lot of times in Cape Town, when we get consulted, families just, you know, our clinicians that consult with us want us to produce this plan, you know, like on day one of the consult. And that's not how it works, because you really need to sit down and have proper conversations with families. And if you start this care timelessly enough, there should really be time for that, because these are really important and difficult conversations. And if you don't do them properly, there's a lot of grief and regret in the bereavement period that's actually unnecessary. So after one's had some time with to have these conversations, then what we normally do is actually to write down an individualized plan that actually can be black and white, so that this is something that the family can have with them and present to the labor ward, or if they happen to not be in the setting in which they had booked, it's a plan that they can present wherever they are going. So it takes these important discussions and decisions, puts them into a document that actually becomes a communication tool, which can ensure a continuum of care, irrespective of where the family land up in the period of labor. All right, so generally speaking, when we're looking at planning for babies in perinatal palliative care, there are kind of two seemingly opposite things that we need to plan for. The one is, you know, a baby who still does have a chance, where we're actually going to decide, right, we're going to do as much life-sustaining interventions after delivery as feasible. Obviously, sometimes needing to put a line in the sand where some of those might not be applicable to that particular clinical case. Or we might actually decide from the beginning that actually the prognosis is very poor, the quality of life is not going to be great, and we're actually not going to go the interventional and resuscitative pathway. We're going to go more down the comfort-focused or palliative care pathway. Obviously, you know, it's not always black and white, and often we are dealing with uncertain prognosis. And in instances where we don't know where we're going to be going, there is the concept of parallel planning, meaning you can actually hold two opposite goals at the same time. You can hope for the best on the one hand, but also prepare for the worst if the best doesn't come to pass. So it's one of the dichotomies in palliative care that we quite commonly have to hold. All right, so just to delineate a little bit of stuff that's usually included in a birth plan. Obviously, very important, we look at what delivery preferences the family have and how possible this is going to be. Is this going to be an induction, a Caesar, or a normal delivery? Who will be participating in providing care? Does the family prefer to have a midwife there? Is there a doula that they have arranged? And these people can play a very important role, especially in the psychological, emotional, and spiritual care of the mother in labor. Obviously, very, very important, especially when the baby is deemed to possibly die quite soon after birth, to try and decide who should actually be present during the birth or be available to visit as soon after the baby is born. Then we need to actually decide, are we going to have fetal monitoring, yes or no? Obviously, the resuscitation status might dictate whether or not we're going to monitor the baby antenatally. And then very important to decide on resuscitation interventions before the baby is born. And that's especially important because the team that makes those decisions is not necessarily always going to be the team that's on call that evening. So very important to have these documented up front. Another very important thing to discuss before the baby is born is, how is this baby going to be fed? Are we going to try breastfeeding, or is this going to be a severe abnormalities? We will actually withhold feeding, and we're going to be talking a little bit more about that later. Or will this be a baby that will be artificially fed? Very important also before the baby is born to decide on any spiritual considerations, such as rituals like christening, and having the priest on standby, or having a hospital chaplain to help with that. And if that's actually part of the plan, it really helps to make sure that that happens irrespective of what time the baby actually gets born. And then also very important part of the birth plan is also to include a list of the kind of memory making things that the family would like to do. Do they want to do handprints and footprints and photographs? Some cultures, these kind of things are not acceptable. So don't just assume because you think it's a nice thing to do, that is what the family is going to want to do. So it's always useful to have these discussions before you are in the moment. All right, so part of perinatal palliative care is also advanced care planning. And it's really, as the name suggests, planning in advance on how you're going to manage a particular situation that will arise after the baby has been born. And like with a birth plan, it's not just a document that's produced out of thin air. It's something that is put together after a series of discussions with a family, and a lot of decisions that are then made based on their values. And it's often not a once-off conversation. Sometimes you do need to have multiple conversations, and sometimes, as I already mentioned, we may have got it wrong. The prognosis may not have been as bad as we initially thought it would, and that plan does actually need to be revised. No advanced care plan is ever set in stone. It often needs to have ongoing evaluation. So key components of an advanced care plan is, what are the family's goals of care? What are the parents' wishes for themselves and for the baby? What are their emotional and spiritual needs? And also, as we already mentioned, parallel planning for two different possibilities, either survival or death. Very importantly, and Julia's going to go a little bit more into this, is to preempt the distressing symptoms that might arise, and to make plans for their management, and also to determine the intervention levels and resuscitation status of the baby. And also needs to decide beforehand, how far are we going to go in terms of ongoing further investigations. We also need to include information on the psychosocial needs of the mother and baby, as well as the rest of the family. We need to make very important decisions about the place of care. Do the family want this to happen at home? Do they want to take the baby home if that's feasible? Or if they're not able to look after their baby at home, is there another facility that can manage this child, or will this be an in-hospital death? And where are we going to plan for the end of life event? What is the family's preference, and also what obviously is realistic? And then once this plan is drawn up, also very important once again to document it and make sure that there are enough copies to hand out to the family doctor, the neonatal unit, if there is a palliative care organization, to send one to them, as well as any other local community resources that might be involved in the care of the baby if the baby is actually being sent home. And once again, like the birth plan, actually is a document that can actually ensure that there's continuity of care, even in the absence of a formal palliative care team. All right, so that's just my introduction to perinatal palliative care and how to do a birth plan and how to do an advanced care plan. And I'm now going to hand over to Dr. Julia Ambler, who's going to talk a little bit more specifically about the kind of care and support that we would offer in the neonatal period to a baby that has survived. Thank you very much, Julia.
Thank you so much, Michelle. I think that really was very, very comprehensive, and it's lovely to be here this afternoon with everyone. We're going to move on a little bit and look at how do we support the baby and think about the symptom and pain control that we need in terms of looking after that baby after it is born. If we can move on. So Michelle's spoken a little bit about the advanced care planning and planning ahead. And I think the words she used most often is intentional planning. Sorry, I see my video's just gone off. Second. So I can see that I'm trying, sorry. I can see that the words that Michelle has used are very specifically intentional, planning, communication. These are all fundamental parts of perinatal palliative care. And the first thing we need to think about is whether we've done it antenatally, as Michelle has spoken about, or now that the child is born and suddenly we realize that there's a problem. Now we need to think about what are we trying to achieve? What is our goal for the child? And taking into account the psychological status of the family and everybody around, the social circumstances of the family, their spiritual beliefs, as Michelle has alluded to, and the physical condition of the baby. We then need to sit down and think, well, what are we trying to achieve? And our point here is we need to understand the medical facts and the medical issues that are going on, but we also need to understand what the family's goals and values are. Our role is to try and advise them as best as we can, given what we know, but you can't really offer advice to a family if you don't know what they believe or what they think, or what are their biggest fears. So thinking about the child with a very serious heart problem, what do you want as a family? We can't fix this issue. You've had spoken to the cardiologist, the cardiothoracic team. We understand that this is a baby who is potentially not going to survive very long because there's nothing medically we can do to intervene in terms of the underlying condition. Given that you know that, where do you want to be? What is our goal? What are we trying to achieve for the baby? And having real, honest, frank conversations is the most fundamental part of palliative care in this area. So once we've decided what our goal is, we need to think with this neonate, how are we going to feed this child? Are we going to tube feed? Are we going to cup feed? Are we going to breastfeed? Are we going to do drops of express breast milk into the mouth? Depending on what we've decided that we're trying to achieve, whether it's full nutrition versus just feeding for comfort, will change everything for that parent. But feeding is such an emotional issue, and I know that our next speaker is going to cover a little bit more about that. But we really need to help families to understand that we only want to do what we need to do for the child in terms of making their life as good and as long as possible. Not just as long as possible, but as good and as long as possible. We need to think about our own motives and whether or not we're influencing the parents on the feeding, but really coming back to what are we hoping to achieve for the baby? How is it best to feed this child? Too often we instinctively, automatically slap in a nasogastric tube, but it's not necessarily going to change anything. So next, Michelle. So we need to think about where we are in the disease trajectory or the condition of the baby. When a baby gets to the actively dying phase, so they're no longer hungry, they're becoming less and less hungry, in fact, they're not showing any signs of hunger, so they're not rooting, they're not crying. The result is actually they become, when we don't force feed a baby, they actually become a little bit ketotic, which means they, for those the social workers that might not know what ketosis is, it's when the blood becomes a bit more acid, and that in turn is part of a beautiful cycle of death. That sounds terrible, but it is. It's part of the plan and the design of death, that when you are less hungry, you become acidotic. The acid then suppresses the hunger responses, and it also helps to release the internal endorphins, which are the body's natural painkiller. So feeding a dying child or a dying neonate is really quite, it's an invasive thing to do. Unless the baby is crying and looking for food, we do not need to feed that baby. We might want to look at how we're going to make the mother comfortable, how the father comfortable, but we really need to get everybody onto the same page, because feeding an actively dying neonate is really not going to benefit the neonate at all. Next. So really, we've got to come back to focusing on what is actually going to benefit the baby. So then the next thing to decide, once we've decided the feeding and our goals, well, what are we going to do to achieve those goals? And in fact, what are we not going to do? So if we're thinking about procedures, are we going to do lumbar punctures or, other MRIs or echoes? Or are we going to really thoroughly investigate this child? Or do we already have enough information that means we don't have to do those procedures? Or investigations. If we've got a child with a very, very serious condition, do we need to chase whether or not they have an infection? And treating that infection, is it going to make a difference to what the child is experiencing now? And the chances are, if it's a very serious condition, very life-limiting and life-threatening, it's unlikely to change the outcome in any meaningful or significant way for the child. Similarly, oxygen. Often oxygen is for us. It may help when a child is got low oxygen saturations, but it doesn't necessarily improve how the baby's feeling. So the key is always to look at the baby and not manage the monitor, because the monitor doesn't actually tell us how the baby is feeling. It's much more accurate to look at the clinical condition of the child. Unless you're in a fully active resuscitation where the child, we've got a whole bunch of clinical conditions that we are actively, aggressively managing. But in palliative care, where we're focusing more on comfort, the oxygen is not necessarily going to change the outcome either. And then lastly, monitoring. We really need to think about this. So when the machine is going ping, 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 and I meet with a lot of parents who've spent time in the ICU and after they've lost their child or once they've gone home, they can still get sort of chills up their spine, and it's almost, some parents call it a PTSD, that sense of absolutely post-traumatic stress from the machines and the pinging that comes out of a neonatal ICU. And if that is necessary to get their child well and healthy and discharged, then that's great. But if we've got a child who's really seriously ill and whose prognosis is very poor, having those monitors pinging and bleeping, and chances are they are going to be pinging and bleeping because the parameters are going to be outside of normal, doesn't necessarily help the child, doesn't necessarily help the parent. It can actually increase the anxiety that parents are feeling. So we really need to think about finding the balance between, is it the right thing to do? Is it going to help or not? So Michelle, the next 4 things, if you can just go slowly. So we always have to think, will it help? Will it harm? Next, what do the parents think? And then, have we made any assumptions? So very often we say, oh no, we can't take off the monitor, and the mother will think that we are abandoning them. Okay, why not just have the chat with the mother and say, are these monitors helping you? Because they're not really helping us. They're not telling us anything we don't already know. Is it useful for you to be watching the monitor, or would you like us to perhaps take it off? And we really need to avoid that sense of abandonment, but not making any assumptions when it comes to any of these 4 points on the slide are so, so important. Thank you. We then move on to resuscitation plans. Michelle's already alluded to this in the advanced care planning, but we need to decide, we've got a baby, this is a diagnosis, where are we in the scheme of things? And this kind of discussion needs to happen in the daylight hours, not in the middle of the night. It needs to involve the parents so that they understand what it is and why we are doing it. But to try and, do CPR on a baby that is destined to die early because of the underlying condition is not dignified, it's not reasonable, and it's stressful for everybody. There may be a middle ground where we do offer some form of support, but we need to know, what is it going to be? Is it going to be full resuscitation, no resuscitation, allowing a child a natural death? Or is there some middle ground that we are going to do some things but not others? Thanks, Michelle. Now, any of you who've worked or been a parent in the NICU or have seen babies in the NICU know that it comes with a lot of pain. And that, a preterm, a newborn in the NICU can undergo up to 250 procedures a week. We're looking at tube insertion, venipuncture, heel pricks, the whole caboodle. It is a nasty place to be. I would not want to be a baby in a neonatal unit anytime. So we really do need to be thinking about, how do we manage that? How do we, and I used to believe that, oh, well, it's great, they're a baby, they don't remember it anyway. But that's not actually the case. We know now that that repetitive exposure to painful procedures early in a child's existence can really reset their pain threshold for life. think about how plastic the brain is. All that exposure to that pain really does have an impact on the growing child. So really thinking about what procedures we do and how we manage that procedural pain is super important. Thanks, Michelle. So let's think about pain and distress management. I put distress there because there aren't very many specific symptoms in neonates that need managing, unlike the older child or the adults. But in the NICU, we need to be thinking prevention wherever possible. So not doing things that we don't need to do, really going back to that first slide when we spoke about setting the goals. What am I trying to achieve? And then only doing those procedures or those interventions that are actually going to help the child. Pain management needs to be planned, intentional. It needs to be comprehensive, thinking about the whole child, everything that's going on. It needs to be fully and thoroughly assessed. And then we might use pharmacological measures and non-pharmacological measures always. But if we don't assess the whole child, we don't really know necessarily what's going on. I'm sure when I was a baby, my mum couldn't work out why I was screaming and screaming and screaming. Heavens, thank God that the days of needles, those safety pins are over. But yes, they had a safety pin through the skin. So if we're managing one thing and not thinking about the whole child, we're going to miss something. So this is an example of a neonatal infant pain scale, the NIPS scale. And really, these are so simple to use in your unit, and we would really recommend that you do. Involving them and listening to the parent, it's so important that they are taken seriously. And if they are worried that their child might be in pain, there's a good chance that they might be in pain. And then using our pain rating scales. So looking at things like their facial expression, how much they're crying, and marking it down. And does it matter if I score slightly differently to the next nurse or the next doctor that's coming? No. The idea is to get a pattern, a trend, to see if when we manage the pain, are we actually making any difference? Is this child in fact feeling any better? And there are a number of different scales that you can use, but the NIPS is just one example. And the idea behind this gives you an idea of how to adjust your plan. If you've tried something and after 45 minutes, the child is still scoring poorly on the pain scale, you might want to change your management plan. So what non-pharmacological measures, and these are absolutely imperative in managing the neonate. More so than in older children, but always, we think about non-pharmacological. We know that non-nutritive sucking, or sucking a glucose solution, is more effective than Ambler, according to a Khakhu review. Breastfeeding the child. So what we do is we give the child something sweet to drink a few minutes before, 2 minutes before the procedure, can dramatically reduce the pain that they feel. It's side effect free. Or breastfeeding if the mother is able to do so. Positioning the child. Think about the preterm infant, the way they're supposed to be, nested rather than sprawled out wide. Positioning a newborn is so important, especially in the NICU. Facilitated tucking, making sure that these are principles within your neonatal unit, that the mothers know how to do it if they are with the child in the nursery, and then swaddling that child, making sure they really are nice little samusa. Kangaroo care can make a massive difference, and there's a good reason that we've moved to having so many kangaroo care units across the country. This is skin-to-skin contact, and they can be touching or stroking, but definitely that kangaroo care where the child is on the mother's chest. It is a natural incubator. It is better than most things in terms of comfort and warmth for the child, preventing pain. There might be other things like music and massage therapy, and then also environmental management. Think about the NICU environment. If you've got some nurses who are giggling as they come back from tea, that's lovely that they've had a nice time, but it's loud, it's shocking, it's not necessarily a great noise in the NICU. What about the lights? Yes, it's great if we have proper light when we're doing a procedure, but after that, the lights should be dim, especially when a child is preterm and they're not even supposed to be out in the open. So really thinking about, is the neonatal ICU or is the nursery unit where the child is being cared for an appropriate environment for a newborn? And those are quite small changes, very practical things that you can do in terms of keeping a child more comfortable, keeping a child calmer. Thanks, Michelle. So thinking about things like heel pricks, dressing changes, removal of tape, intramuscular injections, IV lines, all of these can be done using any one of these techniques, particularly the non-nutritive sucking or breastfeeding. But these kind of non-pharmacological methods really help. And then make sure we're minimizing and clustering any routine procedures. Don't heel prick now and then come and change the nappy in 15 minutes and then come and change the orogastric tube in 15 minutes. Disturbing a child many, many times like that is just, you can imagine if you're an adult trying to recover or grow an award, it would make life very, very difficult. The pharmacological management of neonates is relatively easy in palliative care. It's not that complicated. I think people get worried when they see a tiny infant, but actually there's a lot we can do with very, very little. The principles are the lowest dose of any medication for the shortest duration, balancing always the benefits with the side effects, avoiding using too many medications at any one time, and not to forget using topical analgesia like Ambler or an anesthetic cream, along with all of our non-pharmacological methods. So for mild to moderate pain, we would suggest paracetamol. For severe pain, morphine, and this can be given orally, subcutaneously, or intravenously. And I've left out the doses because I don't think it's relevant for the webinar, and you can find them easily on the internet, very well-established dosing guidelines for the age and the route of administration. Thinking about other symptoms that we might get, probably the most common that we get referred is secretions. A baby that's really just producing a lot and not coping with them. So the most commonly used medication that we have, and maybe the others can contribute in the discussion time, is atropine eye drops. Not always very effective, but makes a huge difference. And sometimes it's been the difference of a child having to stay in hospital and be suctioned all the time, or being able to go home and be managed at home, which is obviously much more comfortable. Constipation, again, not a very common side effect in this age group in palliative care, but we can use lactulose if we need to. Otherwise, there are lots of other more natural things. Parents may try sugar water or prunes. Parents come up with their own thing, but it's good to discuss it and have it out in the open. And then any kind of distress, and it's most often respiratory, but if the analgesia is not working, the pain management doesn't work for a child, we might need to give a little bit of palliative sedation, and that would usually be midazolam, but again, not forgetting the non-pharmacological management of the child or the baby. So in summary of looking after the newborn in the neonatal period in palliative care, we really, it comes right back down to the goal. If you don't know what you're trying to achieve, we all end up just doing what we do because that's what we do. We do glucose monitoring this often, we do this that often, and it doesn't necessarily help the baby. We need to involve the parents every step of the way. We want them to have an opportunity to be normal parents, to have a moment, however brief or however long, they need to be able to play some kind of parenting role. So if they are in hospital, allowing them to more contact with the child, more contact to perhaps even bath or nappy change, things that parents would do regardless of whether their child was sick or not. Assuming nothing. So as Michelle said, you just don't know what people are believing or what they're thinking. So absolutely assume nothing. Ask with curiosity, ask with interest. What makes a difference to you? What would you like? In your culture, your religion, what are the most important things that we learn every day? These are not offensive questions. They are actually just curious and so important in neonatal palliative care. Keeping the baby at the center, coming back to that goal. What is going to make this baby better? The environment in a hospital setting particularly, but even as the parent goes home, talking them through what a suitable environment might be in terms of the lighting and the noise stimulation and other things to make sure the child is as peaceful as possible. Always think about the non-pharmacological measures. And then lastly, we can consider pharmacological measures for these babies.
Thank you very much, Julia. Right, we're now going to move on to Dr. Mathivha, who's going to speak to us about the ethics in perinatal palliative care, with a particular focus on withholding and withdrawing nutrition and hydration, which is obviously a very, very emotive and difficult decision. Thank you very much, Khakhu.
Hi, Michelle. Can you start my video? I'm unable to start from my side.
So can you try and hover over Khakhu's, and there we go. There you go, Khakhu, you're on.
All right, okay. Afternoon, everyone. I'm an employee of Nelson Mandela Children's Hospital, a joint staff with the University of the Witwatersrand. I really don't have any financial sponsors to disclose. Next slide, please. My topic for today, I must admit, was a bit of a difficult one. I'm not an ethicist by a long shot at all. And the one thing when I was trying to do this topic that I realized was in the neonatal period, perinatal period, one size does not fit all. And each and every baby is an individual who will have their own challenges. And one would then need to address them as they come. But just to refresh a little bit for everyone, there are 4 main principles of ethics, but from a clinical perspective, the main principles are autonomy, beneficence, non-maleficence, and justice. And as we all know, ethics is a broad term that covers the study of nature, of morals, and moral choices to be made. So with beneficence is each and every one of us, whether you're a healthcare provider or in any other social context, providing support to any person, you have to act. So in a clinical setting, we all have an obligation to act for the benefit of the patient. And we all have to act, especially in children, if you take the children's rights into context, we have an obligation to protect their welfare. And we also have the right to defend others. So non-maleficence is, we still have an obligation not to harm any patient that we are looking after. Autonomy and self-respect is, we all have, or we should all have the power to make rational decisions and be allowed to exercise our capacity for self-determination, which becomes a very difficult area when you're dealing with the perinatal period and the neonatal period. And this is where the mother or the parent becomes a surrogate autonomous person who will then have to make some of the decisions that are needed. When you look from a clinical perspective, generally justice is fair, equitable, and appropriate treatment for any person. But what is more pertinent in a clinical setting is the distributive justice that we need to consider. For example, in South Africa, I know in most settings, resources are a problem. So you judiciously use resources, and this is where policies, protocols, standard operating procedures come into play in majority of our hospitals. Next slide, please. So let's just go back to the normal neonatal period. In the normal neonatal period, assuming the baby is fine, is normal, the standard of care in a neonatal ICU would include pain management, would include respiratory support, hemodynamic support in any neonate who comes through into a neonatal setting. So we provide assisted ventilation. If surgical interventions are warranted, they will be done. And it's because there's more technologies that have become available. And this, I don't know whether to put it fortunate or unfortunately, this has led to an increase in neonatal survival. It has led to improved patients' quality of life. And also in that NICU setting, we are also then able to be practicing developmentally appropriate supportive care of that neonate. The challenge becomes because if things do not go the way that we expect them to go or according to expectations, we then start getting undesirable effects. And that is where all this technology can become burdensome instead of benefiting the neonate. And especially in situations where the potential for survival then becomes lost. Saying just, for example, if there's a severe neurological injury, for example, severe hypoxic ischemic encephalopathy, borders of viability come into play, where babies have complex congenital anomalies that we are unable to fix. And this is the time where, as clinicians, having the obligation of trying to uphold all the ethical principles and the family included, we all get confronted with challenges in terms of this is our limits as to what medical care can do, and the usefulness of those medical interventions is lost. Next slide, please. So during the neonatal period, so neonatal palliative care, it's palliative care given to a newborn baby who has survived the immediate post-delivery period, as the past two speakers have already alluded to. And the goals of care need to be established, as you've already heard in the previous talks, so that if interventions have lost their usefulness, then we need to move towards comfort of the baby, minimizing the distress of both the baby and the family. Sorry, it's a typo. That is, the level of intervention has to be discussed. The eventuality of the uncertain condition also have to be considered. So care interventions regarding all multiple facets, as you've already had in the past two talks, with a life-limiting condition, nutrition comes into play, hydration needs to come into play, pain management, dealing with all sorts of symptoms. And this is a very important part of the whole perinatal palliative care, because like Dr. Meiring has said, each one of us needs to get involved in this. Next slide, please. So perinatal palliative care, the care intervention goals is ensure physical comfort, care for that baby, manage pain and symptoms. Nutrition and feeding comes into play, as Dr. Ambler has already said. You need to review, reassess, and if it's not going to be useful, then you need to withhold or withdraw. So we also need to consider what are the procedures of further investigations that are going to be done. Monitoring needs to come into play. We need to avoid or minimize invasive procedures that are not useful or are not beneficial to the patients, and they are likely to increase their suffering. Like Dr. Meiring has already said and has put in place, and Dr. Ambler, your advanced care plans, resuscitation plans, these you review on a regular basis whilst you're giving comfort care to the patient. Next slide, please. So in terms of nutrition and hydration, I think in the meeting, we all know in a social context, offering a group of people food when we come together, it's something that we experience almost on a daily basis. As families, we sit around the table, and we recognize also that it's a sign of love and caring. But when feeding does not go well, especially in sick patients. That takes away the route for the caregiver to show that support and love. And for a dying child, to the parents, decline in intake indicates that the disease is getting worse. And this can just compound their frustration, their distress, and grieving process. And in the newborn period, we all know it is a mother's natural response to want to provide nutrition to a baby. And the goal of a mom feeding her baby is to provide comfort, to reduce stress from hunger and all sorts of other things. And it's one of those fundamental rules in human life that a newborn baby needs to be provided with nutrition so that they can grow and get the care that they need. Then the challenge comes now when, as those who are giving healthcare, looking at and having reviewed the whole situation, it does revoke quite strong emotional responses from us as the healthcare providers and the parents, because now we are taking away that way of showing love and caring. Next slide, please. So nutrition may be provided, as we know, by breastfeeding, bottle feeding, or cup feeding. That is in a normal setting where there are no issues. But in critically ill newborns, in all spheres, whether they are in a neonatal ICU or in a transitional care ward, all critically ill newborn infants, nutrition is provided by using assisted measures, such as considering inserting an IV line or a central line so that we can give them parenteral nutrition, or inserting an orogastric or nasogastric tube so that we can facilitate feeding. But those are assisted measures. I've gone through quite a few articles that I still don't have proper answers, but there's lots of debates between artificial and natural feeding. And some of the ethics articles just sort of define artificial methods of feeding as where you're providing hydration and or nutrition, but that requires employment of your nasogastric tube, orogastric tube, a gastrostomy, or an intravenous route where you would be giving total parenteral nutrition. Natural methods are sort of defined as feeding that does not require medical means. So breastfeeding or oral cup feeding, bottle feeding. Next slide, please. So with perinatal palliative care in a NICU setting, neonatal ICU, almost all babies will receive hydration when they are admitted to ICU, and nutrition through medical routes or the artificial routes. So in the early stages of their lives, hydration and nutrition is considered through those routes is considered to be normal. But in the transient neonatal condition, we also ventilate them. We still continue artificial hydration nutrition with the aim and looking at the possibility that the baby will go through those stages and survive and get better. Next slide, please. So in terms of critically ill neonates with all sorts of congenital complex anomalies, when you look at any neonatal patient who's in an ICU, when you're doing medical hydration and nutrition, it's part of standard care during that stage. And we then expect the baby to improve and no longer need artificial means of nutrition or hydration. And in that setup, this is the part that makes sense to us as clinicians, where we carry on feeding, carry on giving intravenous fluids, giving total parenteral nutrition, because we can see when we review and assess, the neonate is going to get better, improve, and we would be able to discharge the baby home, and they would no longer need that. The biggest sad part is when those intravenous nutrition or artificial nutrition routes prolong intractable suffering, because really there is futility in play, or when it extends life beyond the point of being beneficial to that infant because of their complex anomalies. That is where then the ethical justification loses its meaning. Next slide, please. So in perinatal, when we're practicing perinatal palliative care in a neonatal setting, when you look at all those 4 main principles of ethics, so this is where then the clinician and the team that is looking after that neonate need to start planning decisions to stop medical therapies because of futility, of poor prognosis. But like I said, one size does not fit all. Each and every baby is taken as an individual. Then the next thing is to look at what are my goals of treatment where there's futility. And these are goals that need to be discussed, where parents get involved and we listen to them and we hear their say. And then we are then able to make a plan to say, these are the level of interventions we will undertake. And these are the things and these are the goals, like your comfort, management of pain, symptom alleviation, and all these things we need to take the parents with and explain as we go along in the care of that baby. So in a situation where having to do oral feeding in a critically ill baby with a life-limiting condition, where then it warrants you to put in central lines to give total parenteral nutrition, but the end goal is still the same, that the baby will ultimately demise. So you need to discuss all that, and oral feeding then should be withheld. Withdrawing feeding is also an option where if you find that when trying to feed, even if it was through an oral route, is causing quite a lot of pain and distressing symptoms to that baby who's got a life-limiting condition. Artificial hydration, as I said, it would be giving IV fluids, giving total parenteral nutrition. In a lot of settings, it becomes a big challenge. But when you go and you try and apply the rules or the ethics principles, even though one size doesn't fit all, you also then would look at what are the burdens of, for example, me continuing total parenteral nutrition in a patient who the oral route is not feasible and the prognosis because of the congenital anomalies is very poor, and this is an undesired outcome for the parents. You then would look at the complications that would arise. For example, when you're giving total parenteral nutrition, you do need a central line. You need a large borehole. Does then that mean I'm going to change lines every, let's just say, for example, 10 days? Does that not subject the baby to more pain? And that's where then you would look at the burden and the benefit, and also the other complications, sepsis that would come into play, liver failure, your cholestasis from total parenteral nutrition for prolonged periods of time. And also then you would then go to look at your justice part of your ethics to say, am I distributing my resources adequately so that everyone else can benefit? Next slide, please. So I've just got a case that I had at Nelson Mandela. I just also want to disclose, I did get permission to discuss this case. I haven't mentioned names, but I'll just give you a brief history. And that's where I found that just trying to go through those principles of ethics also helped us as a team to get to a point where we were able to discuss issues with parents and also hear their concerns and make a plan going forward on how to manage this baby. This was a baby who was a term baby, about 3 kgs, normal upgas. The only thing antenatally during the pregnancy, mom had an antenatal fetal anomaly scan, and the baby was picked up to have posterior urethral valves with bilateral hydronephrosis. Post-delivery, the baby had severe abdominal distension and was having biliary NG aspirase on day 1. So no renal abdominal sonar could have been done at the time at the base hospital. Baby was referred to us at Nelson for surgical intervention. So for bowel obstruction. So bowel obstruction in a newborn with severe abdominal distension, which was actually compromising respiratory functioning, the baby needed to be intubated, was considered as an emergency. Baby was taken for an exploratory laparotomy, and intraoperative findings at the time, what was reported was there was malrotation and a large meconium plaque, which was milked. And from there, that is the time when we were looking at this would be the normal of the male neonatal ICU management. It looks like everything was sorted out. Meconium plaque was removed, the malrotation was sorted out. And we at the time expected a good outcome because we thought in about a week, we would be able to start feeding baby and weaning the ventilator off. And this is a baby who potentially will be able to go home, will not need artificial means of feeding at some point. So we commenced total parenteral nutrition at the time. And the goal at the time was short-term total parenteral nutrition until we are able to get the baby off the ventilator and we are able to initiate oral feeds. A VCUG was done. There were no posterior urethral valve features detected. There was no vesico urethral reflux noted, but of note, there was a vesico-urethral diverticulum. Next slide, please. This is a baby who we continued tube feeding because he was still on the ventilator. Then we were able to extubate the baby, weaned from nasal prongs to room air, but due to feeding problems, was still not able to swallow nicely. We were tube feeding. Unfortunately, feeding was not successful. On 2 occasions, he kept on developing severe abdominal distension and feeding intolerance with bilious nasogastric aspirates. So for about a week, and a few days, it was just trialing feeds on and off, and he kept on having this severe abdominal distension. Contrast study was then performed, and it then indicated partial bowel obstruction. From the surgical team, surgical intervention came into play. They trialed a nasojejunal feeding tube to bypass the pyloric sphincter. Unfortunately, for that whole week, also feeding was attempted, no success. He kept on having severe abdominal distension. The baby had to then go for a relook laparotomy, and the diagnosis then was made that he's got a megacystis, microcolon-intestinal hypoperistalsis syndrome. Parents were informed about the diagnosis from a surgical point of view and the poor prognosis that comes with this diagnosis. At the time, we then weaned the baby post-laparotomy after about 3 days, post-operatively pain controlled, and we successfully extubated the baby to room air. Total parenteral nutrition at the time was continued, whilst we now needed to redirect and plan and re-counsel parents because now the prognosis was not the desirable prognosis that we had expected a week or so earlier. And we then involved the whole multidisciplinary team with our psychologists, our surgeons, and the neonatal team and nursing staff. And then after about 2 to 3 days of discussions and listening and attending to the parents' concerns, we then redirected our care towards palliative care, comfort care, managing pain, managing symptoms. Next slide, please. So I just put in the 4 ethical principles again. When you relook at this case, respect for autonomy, yes, patients have to exercise their rights. They have to be given information, the benefits and risks, which initially at the time, yes, the parents have taken over the giving of consent. We were informing the parents. The initial part of the whole management process was more to explain, give them information, and get consent to do the initial agent laparotomy. So those were information given to the parents because they were the surrogate person who had autonomy to rights for this baby. Baby is not mentally competent to then could have given us their consent. Then the do no harm and do good at all expenses. We then initially, clinical assessment was, this is a bowel obstruction. There was malrotation, which is something that could have been, that was correctable, and the meconium plaque that was dealt with. And we then thought initially, this is where we go. We're gonna treat the patient with the hope and we expect the baby to make a full recovery. But then when things changed and direction changed, when everything that we were trying to do in terms of treating with our goal of having a baby who would go home did not work, then when the relook laparotomy came into play and the new diagnosis came into play, we then looked at what are the treatment options available for this megacystis microcolon hyperperistaltic syndrome. Is there any treatment that could fix or make or alleviate the issues so that we would be able to feed? We looked at what would be the adverse effects of if we do treatment. Treatment would probably be coming from a surgical point of view. What surgical intervention would the surgeons help us with? And also we then looked, would treatment benefit or will harm be more and outweigh the benefits if we do go ahead and do the surgery? And then we also looked at, in this situation with this particular diagnosis, what is the effect of not doing any surgical treatment or doing surgical treatment? And if there is medical treatment to treat, what is the effect of if we don't give any medical treatment? And then we then reconsidered once we got a meeting with the surgeons. They were the expert in this condition, it's a surgical problem, and they had then given us answers. And then we looked at, this would be what would limit any form of treatment, and whether stopping treatment, does it benefit the baby or does it do more harm to the baby, but also considering what the parents' feelings are and their emotions, and what does continuing with treatment that is not beneficial to the baby do to the parents. We also then looked at what quality of life, if we are giving treatment, will the baby have, or what quality of life will this baby have if we don't give treatment. Then we then looked at, because with this baby, the bottom line is there really was no proper good functioning bowel to can sustain feeding or life. That is where then we looked at limiting, because with palliative care, my understanding is we shouldn't be prolonging suffering, and we shouldn't also delay a baby dying. We should also not hasten death. But if all the interventions that we were looking at were going to harm the baby, then it defeats the purpose of us instituting those. So we looked at And the resources that we have in a state hospital allow us? No. Next slide, please. I think this is my last slide. So just a little bit about megacystis microcolon-intestinal hyperperistalsis syndrome. It's where intraoperatively you find that there's a massive dilated urinary bladder. There is malrotation. The whole colon is very small. And then he also had segmental stenosis of the small bowel and the duodenal web. Complications of that, they get intestinal failure because they become a short bowel syndrome. And surgical manipulation of the gut is generally frustrating and has always been unsuccessful in the cases that we've looked at with the surgeons, which means TPN is required. And the outcome is generally fatal. So with this case, then when we discussed, the conclusion was, if we do go in cases like this, you should make that decision carefully and individualize it. And in most cases with this syndrome, surgical intervention has not been helpful and it's a futile exercise. Next slide. That's my last slide. So that's it. These are just my references. The case, we ended up redirecting care and doing palliative care. We did engage mom to inform her that we do have Lambano, we can consult them and they can come in, and the mom felt it's better for her baby to demise at their nearest hospital, the base hospital where she was referred from. We do discuss with the pediatric physician there, who was then willing to take over and manage the baby. And the report back that I got, I think after 2 weeks, is that the baby subsequently demised. Thank you.
Thank you very much, Khakhu. Complicated case, an excellent demonstration of ethics, and also how we need to sometimes change track as new information arises. Thank you very much. Just in the interest of time, I'm going to move us through to our next speaker. If there's anybody who joined late, won't you please just put your name, your profession, and where you come from? It's just interesting to know who's on this call. All right, so our last speaker of this afternoon is Tracy Rawlins, who you've already seen. So Tracy.
Thanks, Michelle. Will you start my video? Thank you. Okay. Good afternoon, everyone. So I'm going to be discussing more of a nurse's role in perinatal palliative care. And I've titled this Journeying with the Family, just because it is a journey from the time of their diagnosis right through into the bereavement period. So looking at my objective, I just thought I'd describe some more practical nursing interventions that will provide care and support to both the baby and the family, especially the mother when the baby is at high risk of dying before or shortly after. Okay, so I thought I'd take a step back in time, and I've never forgotten the topic or the title when I started nursing, that we were going to be studying the art and science of nursing. And just throughout the course of my years of nursing and where I've got to now, I've just really come to understand that nursing is definitely an art, and it includes very many areas that from our affective domain and not just a cognitive domain when we come to practicing. So I thought I'd look at this quote from Florence Nightingale. She said, nursing is an art, and if it is to be made an art, it requires an exclusive devotion, as hard a preparation as any painter's or sculptor's work. For what is the having to do with dead canvas or dead marble compared with having to do with the living body, the temple of God's Spirit? It is one of the fine arts. I almost said the finest of arts. Next slide. So with her quote there, then I also had done a bit of research into the art of nursing. And I found this this aspect of nursing, an article written by Sai Bali Madethel, sorry, excuse my pronunciation. She's the nursing director at Amrita Institute of Medical Science in India. And she said, the art of nursing is built upon such things as wisdom, compassion, effective communication, and respect for human dignity. It's the ability to connect with those around us and to connect with ourselves. This intangible connection can create an environment of healing, one that allows patients to fully participate in their own process. And lastly, here the nurse, like an artist, transforms what is present to what is possible. And I just felt this was really applicable in journeying with a family that have been given the diagnosis of a life-limiting condition of their baby, because that's what we want to do. We need to help them transform what they had in mind. Next slide. Sorry, can we go back, Michelle? Sorry. So we go back? Back. One more. Okay, so this mum, you can see she's very pregnant. It's a very bright picture. She's got a bright future. She's obviously looking forward to the birth of her baby. She's got the future in place, what this baby might look like, what plans they might be, what the number of siblings might be thinking. So the future is bright. And then suddenly they're given the diagnosis of a life-limiting condition. And next slide, next part. And suddenly what was a bright canvas is turned to maybe a blank canvas or a black and white canvas that has got no color, no purpose, and they don't quite know what to expect. Their worlds have been turned upside down. Next slide. So as a role, nurse's role in this, how can we help recreate this piece of art, this canvas that this family now have? They've lost that picture. I mean, we've spoken about pictures paint 1,000 words. They had a picture of where they were going. So we now, in the nurse's role, alongside the team, have to recreate this journey for them by painting a new picture. Next, please. So we do this in the antenatal period through communication and holistic planning, we're starting to paint a new canvas with this. Next section. The intrapartum period, the delivery room care and support to the mother and family, and then into the neonatal period where we care for the mother and the baby, and it includes memory making and end-of-life care. So I'm going to go through each of these different periods and just discuss sort of more practical interventions that we can do, and it's always going to be done alongside the multidisciplinary team with the family at the helm. So when we think about what is important, first of all, it's our most practical skill that we need to have in place is how we communicate. From that time of being given that significant news, their lives have changed. And good communication is an integral factor in providing support for our families, but it's also the most challenging. How people interpret what we say, the emotional responses, the words we use to describe conditions, the language barriers. These all work to confound good communication. I know it's as healthcare professionals, we speak a different language to the normal person. We talk about it we talk about medical jargon. But what do terms such as fetus, prima gravida, incompetent cervix, fetal anomalies, fatal diagnosis, what do those mean to a mother? She doesn't understand those words. All of them are fraught with negative connotations. We need to be aware what language she's using, what language the family are speaking. So again, that goes back to just how do we communicate from that first meeting with them. We need to create a safe space. We need to build a relationship with this mother and her partner and the family. And from the get-go, we've got to emphasize that for this time, however long, however short, we're going to focus on living the life of this baby from now. When we're doing these communicating, we need to take into consideration the cultural and religious beliefs, aspects. Who makes decisions in this family? Is it the head of the home? Is it somebody to do in the church? Is it an elder? So we need to be very aware of cultural and religious considerations. And again, what language barriers are there? Are we in a diverse culture in South Africa with many different languages? They're moving from provinces to institutions. How do we communicate? How do we break that significant news? Who is interpreting? Is it just a family member? Is it fair to put that pressure on the family member who are interpreting? Do we have skilled interpreters sharing all the significant news, the considerations that need to be taken into place? And then we have to think of the team approach. This is definitely a multidisciplinary, multi-layered pathway and journey that we're taking. There are so many people who need to be involved. And as Michelle mentioned in the beginning, they're going to move from one place to the next. It'll be obstetrics, and then it'll be labor, and then into postnatal period, which could be the ICU. So who are we communicating? How are we referring? How is this continuity of care being provided? So we need to look at how we support. So how do we maintain that communication with this mother, with the family? How do we provide the ongoing support by preparing them? We spoke about hoping for the best and preparing for the worst. We need to be available. It's about staying in touch with that family, understanding where they're at, what are their hopes, what are their wishes, and then just also continuing the mother for a normal pregnancy, what changes she's likely to experience, preparing for any potential pregnancy problems. And then, especially in the antenatal period, we want to focus on facilitating attachments, the bonding right in the beginning. Is she still feeling her baby kick? Encouraging talking about her baby. Encouraging if she's going to be going through to having a stalk party, having antenatal classes. She's part of a group. She might have been. She might be part in the sort of fetal maternal unit. There might be groups. She needs to facilitate attachment. We need to start talking about creating memories. Do the family want to create memories? How can we create those memories? Just listening to the heartbeat, taking the heartbeat, recording that, keeping that can be one way of creating a memory in the antenatal period. And then, of course, from the time that they're given that significant news, there's going to be anticipatory grief, all those losses of what they would have expected in the future. We need to understand and identify, do we need to refer? Are they needing to be counseled? Are there places that they can be sent to? The psychological, emotional, and spiritual areas that we could support to. And then importantly, we've spoken quite a substantial amount on this, is facilitating care planning, which includes birth and advanced care plans, and of course the parallel planning, that hoping for the best and preparing for the worst. Next slide. Okay, so Michelle did speak about this birth planning. I'm not going to go into the advanced care plan. I just thought I'd just quickly again go over the aspects of birth planning. So by putting a birth plan in place, we're helping navigate this journey. It's a way of communicating and documenting what this family want. What are their wishes? On the right hand side is just a picture of a perinatal palliative care sample birth plan, and what would be on that. In our book, the Perinatal Palliative Care Handbook, we do have a checklist as well. So if you are looking, these are available on the internet. There are many, many resources that will give you plans that you can print out and then adjust to what your institution or what your protocols and procedures may be in the hospital, what you can offer and what you can't offer. So when we help create this birth plan, just some of the things that we need to consider. What things are important to the family? And Michelle spoke about it. Do they want to have any full resuscitation? Sort of, what are they going to be wanting from if the baby's born alive? If the baby dies in utero, what do they want? Do they want to have siblings and family around? What religious rituals may they want to happen if baby's likely to die soon after birth? Have we discussed those with them? Do we know what their cultural practices are? Who do they want in the delivery room or close by? What family members, if any? Often these mums who have babies with life-limiting conditions, they've been moved from their places, might be from a rural area into a suburban, into a bigger tertiary hospital. Who do they have close by? What support are they going to have? Then the question about, do they want their baby monitored in labor? To what extent? Have they named their baby? Michelle and Julia both spoke about that. What is if they need to give their baby a name? It's so important, and just a really aspect of care, just to be able to mention that baby's name once you have it, and not just go he, she, or it. Their baby's meaningful. They want their baby to know that their baby will make an impact. Then any special items of clothing that they want to have with them, that they might have been given to take with to the hospital. What would they want? Feeding, we've spoken a lot about feeding. What interventions, what level of feeding are we going to do? And then memory making, what will they? So that is all included in this birth plan. And then again, communicating this birth plan to all providers. It really does need to be shared amongst the different providers, the obstetricians, the labor ward, the midwives, the postnatal ward, the NICU if it's going to a NICU. And then the parents also should be given this plan, because they might not be in the place where they had planned to have their baby. They might be somewhere else. So it's such a good idea to have this plan spread far and wide amongst providers. Next slide. Okay, so let's look at the intrapartum period. Mums manage to carry baby to term, or maybe going into prem labor, but she's in the delivery room. And this is where your midwife, your labor ward nurses play such a big role, because we need to consider that this time might be when they say hello and goodbye at the same time. This is a sacred time for this family. So we need to make this environment sacred as possible for them as well. So if we've planned a palliative approach, we need to look at what the goals of management are. We need to create a conducive environment as much as possible. In a theatre or in a labour ward, what have we got in place? Is it busy? Is it people running around? Try and as much as possible to keep the same nurse involved from the time of labour into the delivery room and afterwards. Just creating that continuity of care, that trusting relationship they've built up. Then the goal is going to be holistic comfort for the baby. Has this been planned in the birth plan? And what does this holistic comfort care look like for the baby? We've got to know there's always something we can do. And in the next slide, we'll discuss what this holistic comfort care looks like. Then the biggest thing is to encourage opportunities to bond and interact with their baby as soon as it is delivered. So how can the nurse be prepared? She needs to know the diagnosis, understand the terminology that's been explained, what has been explained to the parents, know their wishes, know the name. And then if she does know the diagnosis, what does she need to have in place at delivery? Dressings for anomalies, clothing, blankets. If you think of an encephaly, that baby, is there a little hat to cover their head? How are we going to present this baby to mum and dad if they're there? So those are things that we really need to consider. And then also to have in place memory making items. Are you going to do videos, camera, stamp? Because as much as we don't want to rush the process, if this baby is likely to die in the delivery room, we want to have those things in place and not be running around looking for ways to make memories. Next slide. Okay, so then aspects to consider after delivery, we need to address the following. That immediate assessment after the baby is born. We might have that birth plan in place, but as Michelle said, miracles happen. The baby could be in far worse, better condition, or live longer than expected, or maybe deteriorate much quicker. So that immediate assessment is important to determine if what is in that birth plan needs to still be implemented. And then, having discussed what routine newborn care are we going to do? Are we going to be giving the vitamin K? Are we going to be doing APGAR scores? Are we going to be monitoring vital signs? Those are things, is it necessary if this baby's not expected to live long? And then the decision that's been made regarding resuscitation, we've spoken a lot about whether it's full, there's some intervention or none. And then the holistic comfort care to be provided, the pain and symptom management needed, and if a baby's deteriorating in the delivery room, is this in place, what we might need to do for the distressing symptoms if they happen. And then what rites and rituals to be formed? What do the family do? Is there a spiritual worker who's around that might need to be called? Or they might want to baptize, they might want to have a naming ceremony in there if that baby is not expected to live long. So all of these things need to be considered before we go into the labor ward and delivery. And then if the baby does live longer than expected, we need to have prepared the NICU, or where is the baby going to go if there is a NICU? Is there a nursery? Is the baby going to have to go into the ward with the mum? Those are all considerations that will impact how the parents handle and come to terms with where they're at that time. Next slide. Okay, so when we look at holistic comfort care, what does that include? So we talk about bonding, that skin-to-skin touch, holding, feeding, bathing. What opportunities are we creating for bonding in the nursery where we can, when that baby's being delivered? How can we maintain their body temperature? Again, are we going to do skin-to-skin contact? Is there a warmer blanket that we can put over the baby? Is the baby going to be going into an incubator for a period of time to get warm? And the relief of hunger or thirst, if that baby roots or turns its head, are the mom going to be allowed an opportunity to offer some drops of colostrum or put the baby to the breast? Are we going to want to use a syringe or an NG tube as the last resort to relieve that hunger or thirst? But we have to identify if that baby looks like it's going to want to root and drink. Can we do that without causing discomfort? And then the last part of holistic comfort care is the alleviation of pain and discomfort. And again, Julia spoke in depth about what we can do, all the non-pharmacological management, and then pain meds and sedation that we might need if baby's in distress. And then again, the non-nutritive sucking plays a big role in relieving pain in newborns. Next slide. Okay, so other considerations for this family when the baby is born. We need to provide support that is holistic. So it needs to meet all the physical, psychosocial, and spiritual needs of this family. We need to have considered them all. Who is there to provide that support? Are you as the nurse going to provide it, or have you got team members that will be able to meet those needs? Again, we have to be non-judgmental, offer sensitive care and comfort to baby and the mother. We might not agree with what they've planned, what they're doing, how they're acting. I mean, we've got to think that if the baby deteriorates, mom might be hysterical or very emotional, or maybe choose not to even see her baby or hold her baby after it's been born. Are we coming in with a non-judgmental attitude and supporting them where they're We have to ensure non-medical explanations, and it's so important to talk them through what they're experiencing. This is happening and what you're going to be doing next, but let it be non-medical so that they understand and are reassured that you're doing the best. Again, it's come up so multiple times. We use the baby's name if there is one. In some cultural practices, we do need to respect that you don't name a baby immediately before they're born, so they might not have one, but we need to have just identified if the baby has a name, talk to the mum, talk to the parents about their baby with the name, Peter, Paul, Sally, whatever. Then prepare and describe what they're likely to see. And I think this is so vital. Especially if there's anomalies, prepare them what they see. Where you can disguise them, do those. But please prepare them what they're likely to see and what to expect next. They need that guidance. Their worlds are in a turmoil and they need that guidance and support. Reassure parents it's also okay to feel differently about the baby. I mean, they might have anticipated how they would react, and their reactions might be very different to what they initially should. And reassure them it's okay. It's okay to feel the way you do. Respect their wishes if they choose not to see the baby. We've got to understand that they might initially not want to, they might change their minds, but you've just got to offer them those opportunities. Very importantly, if the baby's death is imminent, please don't rush your procedures, the time. Allow them to say goodbye, allow them to spend time with their baby, saying goodbye. And where possible, allow other family members to meet the baby. And I just love this picture. I just spoke volumes. It's so important. I think Julia and Michelle spoke about the importance of the siblings and where they need to be included as part. So if the labor ward, the delivery room allows for baby to be introduced to the other family members, please consider that. Next slide. Okay, so how do we support in the neonatal period? And it's we've spoken a lot about pain and symptom management and feeding. And so I'm basically going to just go over some of those points and then just focus on a few things. So again, we have decided that this approach is going to be a palliative care approach. So how do we care for the baby? What do we need to do? So where's the baby going to be cared for? In the NICU, in the nursery, in the ward? If the baby's in the nursery or the ward and the NICU, what type of environments have we created? Is there privacy? I think that's so important. If the baby's in the ward with the mum, has she been provided privacy? Is there a private room she can go, especially if this baby is likely not to live long? Have we decided the comfort care measures only, and are we allowing them those comfort measures, opportunities? The pain and symptom management, are we following the birth plan and the advanced care plan? Again, we speak about avoidance of painful procedures and the interventions that we want to take place. And then we've got to consider what's going to happen if the baby survives longer. Where's that baby going to be transferred to? Where's their place of care? Are they going to parents be able to take their baby home if they choose? Is there facilities such as in the bigger cities? We've got Lambano, there's the Butterfly Home now in Northern Natal. So there are a few hospices that are offering services, but we need to, for reassurance for the family, have discussed what they want to do if the baby lives longer than expected. Then very importantly, and I think we haven't spoken much about the care of the mother. So the mum, this is really a really emotional, upsetting time for her. And as much as we want to support her, that we've also got to just consider all the routine postnatal care, her pain management, her expression of milk. Does she want to express milk for her baby? What breast care are we going to offer? And what if her baby dies or she can't feed? How are we going to help suppress her lactation? And when we talk about expression of milk, we can consider, has she been offered an opportunity to offer milk donation, and I had seen someone in the chat put a site there that you could go and look at for lactations, for milk donation. I've also got a link that I will share in the chat after this. Okay, and then what support to be provided at the end of life and beyond? So parents will always remember those last moments before and after their baby died. What you do and say will leave a lasting impression forever. So how did you support the family at the end, at the time of death? Were you available? Did you leave them alone? Did you give them opportunities to ask questions? Did you explain in just non-medical terms what was happening? Did you prepare them the likelihood of what was going to happen as their baby died? They might gasp, the change of color. All of those are very, oh, sorry, my battery's running low. Hold on. Michelle?
Hi.
Sorry, my battery.
Oh, that's okay. Tracy, we're actually running out of time.
Okay, sorry.
Mhm.
Okay. I don't know what.
I think that's your last slide of memory making activities.
Sorry, let me just see. Yes, okay. So then the memory making activities that were so important, we need to consider photos, videos, lock of hair, hand or footprints, a memory box, anything that might represent a memory for them, to keep a keepsake that they would want to. I think one thing to remember is that initially they might not want to do photographs or videos, but if you do feel that you're not invading their privacy, please do take a photo. You can always tell them you've taken one later and put it away. You can discard it. But sometimes later on, they would say they do hope that they wish they'd had a photograph or kept something of a memory. So please just remember that. Okay, I think is that my last slide? Okay, and then I think just to go back to say, have we painted that canvas? Have we recreated a new canvas, a way forward for them that they can start afresh and start looking at how they could add some color to this very dark time of theirs. And again, just to go back to the words of Sayabala, Mathivha, this intangible connection can create an environment of healing, one that allows patients to fully participate in their own recovery process. Here the nurse, like an artist, transforms what is present to what is possible. You are part of the family's experience.
Thanks so much, Tracy. And that, ladies and gentlemen, is why we need nurses in palliative care. I mean, I think that's a beautiful artistic presentation, and you certainly have taken a black and white canvas and turned a really difficult time into something memorable. So thank you very much. I think Julia's now, just in the interest of time, going to move us into a Q&A session. I'm going to stop sharing so we can see some of the questions in the chat.
Great, thank you. So there have been a few comments coming through on the chat, and I'd just like to highlight them. From Janet Stanford, she agreed about the point on wanting to suppress the lactation, which is so important. And Ruti Kevin from all the way from Argentina has spoken about returning normality to the family, which again is sort of really, without being hospital-centric, such a fundamental part of what we're trying to do. Earlier, Dr. Govenders mentioned about the milk bank, and she asks, any advice on moms donating milk? And she shared the link. Anyone got any experience on that and want to comment, particularly? And Michelle, have you had experience with that?
To be honest, I do know that it is possible, but I'm not sure we always think about it.
Dr. Is there anyone on the webinar who would like to unmute and comment about donating milk, bereaved mums donating milk?
Hi, Julia.
Yes,
I haven't had experience with a mom who baby had demised and she would wish to donate breast milk. But I guess also we've never gone to that point where we ask, because normally at the time when really now the baby is demising, we sort of now trying to contain everyone and make sure the parents are okay. But it's something very interesting. I'm just not sure how one would approach it.
Yeah.
Thank you, Nicole Govender, for sharing that link. If you scroll back in the chat, you'll find that link there to the milkbank.org. And again, I think it comes back to this whole thing of presumption or assumptions that we make. And I think similarly, organ donation, a lot of families, when they're losing a small child or an adult or whoever, they have huge meaning in their lives from doing such a wonderful thing for someone else in their child's honor. So I think that's something we really can look at. So thank you very much for raising it, Dr. Govender. I think you've got your answer there. We don't have a lot of experience with that. I've got another question from Tracy. Healthcare providers often fear legal repercussions regarding actions around perinatal care. Then they opt to do rather excess than withdraw non-beneficial or unjustified care. Are care plans signed by parents sufficient to protect healthcare professionals? Anyone specifically want to field that? I'm happy to take it.
Take it away, Julia.
Okay, so to be honest, the signature in itself is never enough to protect anyone from anything. A signature is literally a blot on a piece of paper, and parents can always turn around and say, it was under duress, that made me, I didn't agree. But the reality is, when we are withdrawing, it is a medical decision. It is not a parent's decision. And I think we get carried away with that. And particularly we see it in the private sector, where there is this bigger fear because we don't have necessarily distributive justice to protect us. The reality is, though, we need to act in the best interest of the child. And if we are convinced that that is what we are doing, we need to counsel those parents to that effect. Then the documentation that is required is a lengthy documentation of the actual conversation that took place. So you can't do it word for word necessarily, but what advice I've had from legal companies is to say, make reference to something very specific that they said. The parents were concerned about this for their child, and not just the parents. Diane and Sibakle were very worried about X, Y, and Z, because when you've dated it, timed it, and used very personal references to the conversation, it's very obvious to anyone reading it that that conversation took place. So it's about the process, it's not about the signature. And in fact, you're protected even without the signature, as long as the documentation is correct. And ideally, you shouldn't be counseling people on your own. We should really always have backup, just because it's hard anyway, so it's lovely to be supported, but then as witness as well. I hope that does answer the question.
Yeah, I think, Julia, one of the problems I think in neonates and pediatrics is that, advanced care plans are not like, they don't hold the same weight as they do in adults, where it's an advanced directive that is actually a legal document. The pediatric documents are just guidances. They're not actually set in stone. So yeah, I completely agree with you. I think the best way to do things is to sign documents where possible, but also to really document your conversations. We'll often have a look in files, and people will have long conversations and then they forget to document them, and that information is really important. And also, I think very important, never counsel a parent on its own. Where possible, make sure that you actually have the father, or if the father is not present, and a grandmother. I think always having two family members is very, very helpful in that kind of situation. Don't do them on their own.
Yeah, thanks, Michelle. Then I think we're running out of time, but there's another question from Jodie Wiles in Mpangeni. She says that she finds that some mothers withdraw or disconnect from the child when they can no longer feed them, and they often then resist in connecting in other ways. Is this anticipatory grief? May there be a cultural reason? And how do we best make memories in that situation?
Yeah. Yeah, I've seen that as well, Jodie, and I've often seen grandmothers almost like recommending to their daughters, you know, the mother of the baby, no, don't attach, because if you attach, it's going to make the grief more difficult. Which is, I don't know if it's cultural, I don't know if it's their attempt to protect their own daughters, why they actually say things like that. But it's, you know, and obviously the whole definition of grief is you have to have had attached to something in order to experience that loss. But if you don't attach to a baby, it also can lead to disenfranchised or complicated grief. So we really do try and talk the granny through the thing. We'll often find, I think, one of the things that I've often experienced is that the grannies take over, you know, and they're just wanting to be grannies and they're just wanting to protect their own daughters, but they're also not allowing their own daughters to have that experience. So sometimes there's this dynamic going between the granny and the daughter, and I think that needs to be properly managed.
Yeah, I think the key again is the exploration of the whole lot, is making sure we understand the motives for everything. Any last questions before we wrap up? We haven't had many come in. I just want to point out that Sue Boucher has posted in the chat a whole bunch of links to the Angel Box Initiative, Footprints from Sam, Kangaroo. So there's a lot of things that Tracy Rawlins alluded to that are now in the text box.
Fantastic. All right. Well, I think if there are no questions, I just want to show a few last slides before we close up. You see my slides again?
Yes.
All right. We just wanted to share a few resources. The Angel Box Initiative, and one of our Patch Network members, Melissa Platt, also wrote a survival guide for mothers in neonatal ICU, highly recommended resource. There's also an Angel Gown Initiative, and then also some references to Kangaroo Care, and of course to Kangaroo Palliative Care as well. Yeah, and I just love the saying that Tracy put up for our last slide. There's no foot too small that cannot leave an imprint in this world. And I think, you know, as young as that baby is, or as unviable as he is, he still existed, and he still needs to be dignified, and that family's memory needs to be respected. So I just really think I'd like to bring in that word intentional again. I think so many times we're just so used to these things happening that we don't actually realize the weightiness of this tragedy for the family, and anything that we can do to make that canvas bright again can really be an amazing thing. Just to remind you that this Perinatal Palliative Care book is available on the Patch website. You can actually read it free of charge. You can also order hard copies through the Patch website. And also just to let you know that we have turned our pediatric palliative care Bettercare book into online courses that are available through the Patch Academy, and we do hope to turn this perinatal palliative care book also into online courses, very interactive courses that will help you to go through the content in a very memorable and exciting ways. And then last but certainly not least, just one last announcement. We're very excited to announce that we're going to be having a palliative care conference in South Africa next year. This is the first conference that we've had since COVID, I think. And it's a collaboration between Patch South Africa, PALPRAC, and the Hospice Palliative Care Association. And it's happening in April in Cape Town. The abstracts are open until the 1st of December, which is tomorrow, I believe. So if you want to burn the midnight oil, you can still get one in. But otherwise, please do think of coming to join us in Cape Town next year. I don't know if there are any final words from you, Julia.
I just wanted to say thank you to the speakers. Thank you, Michelle. Thank you, Tracy Rawlins. And thank you to Khakhu for that brilliant presentation. And obviously, thank you to Sue Boucher in the background, who's put it all together and got us all in the same place all at the same time. It's really been a great afternoon. I do also want to just point out there were 2 comments on the chat. 2 of our listeners today have experienced loss themselves at a time when they didn't have palliative care. So really, thank you for joining us. And I hope that you can help us to make it better.
Thank you so much. Bye, everybody.
you.